in his region, and he is one of key hematologists in Jazan region. He established their hematology and leukemia center. He is a member of national and regional committees, including Saudi coagulation, Saudi blood disorder committee. He is a leader of sickle cell pathways and hematology pathway in Jazan. Dr. Hafid will be talking about unmet need in chronic myeloid leukemia. And it's my pleasure, Dr. Hafid.
Thank you, Muhammad, for the nice introduction. Of course, you were my senior and the founder of the service in our region. I would like to thank also the SSBMT and Dr. Ahmed Al-Askar for inviting me in this event, and extend my thanks to our collegian or our friends in parties for their continuous support for this condition, for educational activity. And I will share you with a few slides about medical needs in chronic myeloid leukemia. And different aspects I will discuss with you in these sessions, including the improvement, the treatment goals in chronic myeloid leukemia, that is will meet the unmet needs in treatment of CML and improve their survival and quality of life. And that will also include the overcome the CML resistance and CML TKI avoidance or intolerance with different medications, and the need for new third-line treatment options, and the need for new treatment for patients with T315I mutation. And very importantly and recently is the improvement of the quality of life and economic burden in later lines of CML therapy. First of all, the improving the treatment goals in chronic myeloid leukemia and chronic phase, and the overarching treatment goal in this disease for those patients to live normal lives with minimal unintended effects from treatment. And we have 6 aspects in this track that will help our patient to improve our goals for them. First of all, as patients are living longer with advent of TKI therapy, the quality of life it become very important goal for us and for the patients. And those patients with newly diagnosed CML chronic phase may wish to strive for early molecular response and deep molecular response with the goal of attempting treatment-free remission, which may be of particular importance for those patients of reproductive age particularly. And for patients receiving their second line of therapy and beyond, the treatment goal include prevention of disease progression and achievement of complete cytogenetic response within 12 months of first line, after first line therapy. And the situation a little bit maybe change in resource poor countries with availability of effective drugs, and essential monitoring may be limited. So the goal of treatment maybe remains only the survival. The use of different TKI has led to life expectancy for patients in CML chronic phase almost close to that of general population, and that we always tell our patient, especially the new patient who diagnosed recently, that you are we can say lucky with this disease, that with more patients they are beyond live like normal patients in conditions with good adherence to the treatment and good monitoring. So in the study showed data from several prospective TKI trials showed that 5 and 10-year relative survival in a cohort of 483 patients diagnosed with CML chronic phase was similar to that of the general population, as you see here. By 5 years, around 95% are survived, and by 10 years, around 88% are survived. And that survival is a little bit different according to deeper responses that is correlated with improved overall survival. As you see in complete cytogenetic response 92, that improved to 97 in complete molecular response. Molecular response in molecular monitoring in those patients is important to determining whether the patient are responding well to therapy or not. And there are well-known guidelines in NCCN and European Leukemia guidelines have developed guidelines and recommendations for how often and what type of monitoring, and is very well known to you. NCCN is QRT-PCR every 3 months. That is, if achieved less than 1% every 3 months for 2 years, then the interval will increase 3 to 6 months thereafter. And if there is one log increase in PCR-ABL level with major molecular response, the monitoring should be repeated in 1 to 3 months. And for ALN recommendation that if at least every 3 months, even if MMR is achieved and confirmed. RDW demonstrated that molecular monitoring guidelines are not always followed. Maybe the reason the guidelines maybe are inconsistent between NCCN and ALN, and there are differences in results between laboratory can be caused by lack of standardization, and European treatment and study outcome is collaboration between parties and ALN to standardize molecular testing that has been implemented in Europe. And RDWE based on patient-level data collected from patient chart demonstrated that although sensitive monitoring is recommended, but is not always performed. Sorry, I have some lags in the mouse. The target response milestone for front and second line therapy, TKI therapy, where European ALN recommendation. The optimal, that is at 3 months, should be less than 10%, less than 1% at 6, and less than 0.1 at 2 months, and less than 0.1 at any time. Any deviation from this milestone or presence of high risk additional chromosomal abnormalities or high risk ALTS score in presentation of this patient that will change the track from optimal to warning or failure according to the reading, either more than 10% at 6 months, more than 1% at 12 months, or extra. The target response, again, milestone per NCCN guidelines that showed if the patient either classify the patient to four groups: TKI resistant, possible TKI resistant, TKI sensitive disease, or TKI sensitive disease, and in more response. That is, will recommend some clinical consideration and the option of second line treatment. For example, patient with TKI resistant disease, you need to evaluate patient adherence and drug interaction, and this is important in both groups, either resistant or possible TKI resistant, as well as in both groups. Also consider mutation analysis in both groups, and we consider bone marrow cytogenetic analysis in patient with possible TKI resistant. The options for treatment of the recommendation treatment to switch another TKI and evaluate for transplant, or switch to another TKI, continuous in TKI, other than imatinib, or increase imatinib dose to maximum 800, and consider evaluation of allogeneic. And I remember I have one case maybe 4 years ago. He presented with increase in PCR ABL molecular, and he was in 400 milligram. At that time, he was ineligible to have another type of TKI, increases imatinib to 600 milligram. And since then till now, maybe 4 years till now, he's in major molecular response. So this is, again, is another option. Also another group, according to the optimal, and for the treatment goal, is it the optimal is survival, or the treatment goal is treatment-free remission. So you will make your recommendation according to your goal. Deeper molecular response is associated with the improved and outcome. As you see here, 10% associated with increased depth of response, 1% associated with 12-month complete cytogenetic is correlated with better overall survival, and 0.1 correlated with better progression-free survival and overall survival, and less than 0.1 is associated that I can say MR 4.5 or deep molecular response correlated with lower risk of progression and death, and is criterion for attempting treatment-free remission. Again, deeper molecular response may be associated with reduction in disease progression and improvement in survival. As the results showed from CML study that deeper molecular response associated with improvement in patient with newly diagnosed chronic phase, and showed the overall survival is increased significantly as the deeper molecular response achieved more, from 83 in complete cytogenetic response, major molecular response 88, that increased to 92% with MR 4.5. What about early molecular response that can predict subsequent outcome in patient with CML? The answer is yes, and that showed an overall survival in patient who achieved the early molecular response, that shows 93, versus patient without early molecular response is 56%. As patients are living longer and often remain to care therapy, 4 years quality of life is important treatment goal of those patients. And as I mentioned, this was measured in different tools and scores, and showed that since all patients remain on TKI for many years, they receive therapy indefinitely, and the quality of life will become important treatment goals. And this provide information on quantifying and addressing chronic issues faced by patient. And it was measured here by HR quality of life and symptoms based score, and it showed improvement of quality of life. So in summary, for disease state, the patient with CML-treated TKI therapy may have life expectancy comparable to that of general population. And this is very lucky news for those patients. Over time, the treatment goals have evolved from improvement of survival to prevention of disease progression, improved quality of life, and treatment-free remission. Regular, sensitive, and robust molecular monitoring is required for evaluating and quantitating the treatment response. In some studies, achievement of early molecular response predicted subsequent outcomes, and deep molecular response has been associated with improved overall survival compared with achievement of less deep response. And as patients may remain on TKI therapy for many years, reducing adverse event and improving quality of life have become important treatment option goals. What about CML resistance? TKI resistant data and how multiple TKI switching may affect the efficacy we are seeing in our patient. And the study according to European Leukemia in 2020 recommendation that 10% to 15% of patients are resistant to imatinib as a first TKI options, and less than 10% of patients are resistant to second generation TKI. And the mutation represents the reason for resistant, as they found 1 out of 3 resistant patients in the chronic phase, as compared to increase of this number to 2 out of 3 resistant patients in the accelerated or blast phase. According to the NCCN guidelines in 2023, that among BCR-ABL kinase mutation, T315I confers complete resistant to imatinib, dasatinib, nilotinib, and bosutinib. And asciminib was approved recently for those patients with CML who are resistant or intolerant to at least two prior TKI or having the mutation T315I. So the regular monitoring of the initial response is associated with better outcome as it ensures prompt switching in the case of intolerance or resistant at the proper time. Long-term pattern of TKI switching a patient with CML. The study also showed approximately 28% of patients who received first TKI switched to second TKI option, and nearly 1 in every 3 patients who received second TKI option switched to a third TKI. And the data adapted from retrospective cohort study included patients newly diagnosed with CML between 2000 till 2016 from 10 integrated healthcare systems in United States, and over 2015 to 2018 period, the number of patients treated in more than third line or more cohort increases by 97.6. And interestingly, that found an upward trend of patients treated with TKIs in third line over the years was observed, suggesting that complexity of CML management. And furthermore, the result could suggest the need for novel therapeutic options or treatment strategies for management of later lines of CML. And this data were adapted from retrospective real-world analysis performed using administrative database covering around 15 million cases in Italy. TKI intolerance is another important factor in management of this patient. And as you know, cytopenia is common adverse effect for TKI in our patient, and it differs from according to the type. Anemia, grade 3 to 4, you will find common in imatinib, 400, 800, dasatinib, and increase, and nilotinib 600, and decrease in other drugs. Leukopenia, again, imatinib in 4 doses, 400 or 800. Nilotinib, both 800 or 600. Neutropenia, thrombocytopenia, and extra. A systemic review for a network meta-analysis showed that 46% of CML patients experienced at least one incidence adverse effect while in TKI therapy, and most common side effects showed GI disorder in 24.7%, 17% cardiovascular, rash in 11%, bleeding 10%, and TLS is very rare, represent less than 1%. Hematological adverse effect could be resolved upon dose reduction. A non-hematological adverse effect could cause 30% of patients to switch their medication. And around 59% is the switching rate within 12 months of treatment due to intolerance. And there was no specific baseline characteristic were associated with intolerance. So inability to tolerate treatment is a major obstacle to CML patient adherence. So the adherence again, that is result from most likely from the TKI adverse effect. So they found more than 80% associated with good response regarding the molecular response in MMR or CMR. And as you see here, more than 100% adherence rate result in 91%, less than 99, from 99, 58, 95, 94 with different figures, but less than 80% showed there is no molecular response observed when the rate is less than that. So always we encourage our patient to adherence every day in their life for their treatment. TKI intolerance is a common reason for discontinuation in this patient, and many studies showed different rate of discontinuation either due to adverse effect or due to lack of efficacy. The other aspect of unmet medical needs include the need for new third-line treatment option, and in those patients, in patients with CML who are resistant or intolerant to multiple TKI, the new treatment treatment option in third-line setting is needed. And as you see here, the treatment available for those patients is decreasing the size of patient population with subsequent line of therapy. Like in first line, you can give up to 4, in second line up to 4, in third line up to 4 without first generation. And with patient with T315 mutation can give only 3 options of the third generation TKI and asciminib. So this represents how difficult the treatment becomes with time. The failure rate of successive TKI treatment in patients with newly diagnosed therapy is show that is increases with increase in the lines of therapy. For example, for imatinib, 31% in frontline therapy, that increased to 50% if the patient exposed to second line after imatinib, and that increased to 75. If the patient started with second generation TKI, 13% the failure rate, that increased to 60% to 80%. But ultimately, or the ultimate failure rate in those patients represent 12% in patients who started on imatinib, and 6% for those patients who started as second generation. So the unmet need with each line of treatment with AD binding TKI, the failure rate increase. Thus, novel treatment options are needed for patients in whom more than 2 prior TKI have failed. Mutation also is common in this patient, and in this study, the mutation analysis was performed following failure with imatinib, and again, during treatment with second or third line therapy with a second generation TKI, it showed 24 of 61 patients developed more than 1 new kinase domain mutation, and 11 patients lost more than 1 KD mutation while on their second generation, and of 18 patients treated with third TKI, the 5 developed a new KD mutation and 4 lost a KD mutation. What about the overall survival for patients in later lines of treatment that showed reduce the overall survival for them? As you see in this paragraph, in this retrospective study of those patients who treated with first-line imatinib followed by the dasatinib or neratinib, and in patients receiving second and third-line TKI therapy, 5-year overall survival decreased from 82% to 77% respectively. So the rate of treatment failure with currently available TKI increased with each line of treatment, and currently third-line TKI have off-target activities that can lead to long-term safety issue, and sequential TKI therapy associated with increased resistance. The other aspect is the need for new therapy for patients with T315 mutations. And as you know, asciminib and third generation TKI, ponatinib and olverembatinib are the only currently approved treatment for patients with T315I mutation. As you see here, the difference in mechanism between ATP size and asciminib that is bound to myristoyl pocket. Overall survival was lower in patients with T315 mutation, and it showed 91 without mutation, and decreased to 71 for patients with mutation. And the death rate of CML-related death was higher in patients with T315 mutation, up to 12%, as compared to 4% without the KD mutation. So the treatment options are limited for patients with BCR-ABL T315I gatekeeper mutation, and patients with T315 mutation have poorer outcome than patients without mutation. The last aspect of our unmet medical needs in patients with CML is improving the quality of life and economic burden in later lines of CML. And different score again was measured regarding the quality of life. And one of these score is validated fact leukemia scoring system that represent highest score is the better in the score for the life patient regarding the quality of life. And it was measured by disease stages and by number of treatment, and all showed that quality of life was also significantly lower in patients receiving second and third line treatment than patients who receiving the first line treatment. Again, the healthcare costs are increased with disease progression, that is increase the burden of economic on the countries. And it showed here that with progression is increased up to $143,000, almost $144,000 in comparison to 53 per patient without progression. And the total all-cause medical and outpatient prescription cost per patient a year in the follow-up, it is $280,000, almost compared to $54,000 without progression. So significant increase in the cost for those patients with progression. Again, the healthcare cost increase after each line of therapy, and it showed here the outpatient pharmacy cost, medical services cost that increase for the patient 1 year after first line, 1 year after second line, or 1 year after third line. You'll find the trend increase from 78 to 99 to 181,000 for one patient. In real world evidence study, CML cost increase with increasing line of therapy. Again, that all cause either medical cost, including pharmacy, inpatient services and outpatient services, as well emergency department and pharmacy, and increasing for patient with all causes. It will be you can say up to 10,000 CML related. You can find again increasing the cost up to 13,000, and in other group for third line you will find 17,000 for CML related of 18,000, represent more than 90 or 95%. So similar related costs represented approximately 90% of total all cause healthcare costs, and medical costs were most prominent following third line and were significant portion of overall cost. So in summary, quality of life decreased by increasing line of therapy and with progressive disease. Healthcare costs increase for patients with progressive disease compared with patients who do not progress. And healthcare cost increases by line of therapy as significant increase in third line group. So at the end, thank you very much. And I hope I finish on the time. Thank you.
Thank you, Dr. Marhan, for this comprehensive presentation about chronic myeloid leukemia. Our next speaker, Dr. Michael Morrow, he is going to present challenging cases in chronic myeloid leukemia. Dr. Morrow, he is a director of chronic myeloid leukemia program and professor of medicine in Leukemia Service Memorial Sloan Kettering Cancer Center. Dr. Morrow did his medical school in Dartmouth School in 1994. After his basic medical science in 1990, Prof. Morrow he's now director of CML program at Memorial Sloan Kettering Cancer Center at New York. After receiving his basic science and MD from Dartmouth College and Dartmouth Medical School in New Hampshire, he completed both residency and fellowship training at the New York Presbyterian Hospital in Manhattan. Before joining Memorial Sloan Kettering, Dr. Moro was on the faculty of Oregon Health and Science University for 13 years, where he directed CML clinical trial program and was involved in the early development of and sentinel clinical studies of ABL kinase inhibitor for CML. Dr. Moro clinical expertise in treating patients with CML, as well as other myeloproliferative disorder, including myelofibrosis, polycythemia, and essential thrombocythemia, as well as less common conditions like eosinophilia and mast cell disorder. His research interests are in development of novel agent for CML, increasing option of treatment of free remission, TFR, and plus in addition to functional cure in CML, and identification and management of TKI inhibitor-related adverse event, specifically cardiovascular event. He holds position on board for International CML Foundation, the Max Foundation, and Leukemia and Lymphoma Society. Dr. Moro, Dr. Moro, the show is for you.
Yep, thank you. Sorry, I was still muted. Thank you for that lovely introduction, and what a great overview we've just had of the challenges in chronic myeloid leukemia, all the different elements related to care, the proper monitoring after diagnostics, the changes in therapy and the way that often goes, and of course the burden of costs and quality of life. So that was terrific. Next slide just has some disclosure, just to know I do partner with Novartis and other sponsors working on clinical trial development for novel agents in CML and long-term studies. So there's that. And probably, I think we know that we really have had tremendous advance in CML. We have what's called a spoil of riches. We have 9 TKIs that have been registered in some places in the world. I'm lucky I have up to 6 here in the United States. We have some that have been registered in South Korea and in China only, which may be registered elsewhere. And I think probably the most exciting advance was just alluded to at the end of my colleague's comments regarding asciminib and tackling high levels of resistance, a T315I mutation with perhaps a safer and a novel agent. So we are quite lucky. The field has evolved as such. And as we've probably covered just a little bit, the goals change as you move through therapy with CML. First-line therapy, we're looking at costs and access and optimum response, and we're hopefully risk assessing the patient to understand their CML risk, but then we're also looking at their comorbidities to understand how that might play in. And probably the most difficult thing is choosing the right drug and having a patient adherent to that therapy for the duration. I think that's probably still a challenge. As we get into subsequent lines of therapy, the questions change. The disease specifics really matter. The phase of disease, of course. You may be aware the WHO has modified the criteria, and accelerated phase CML has been phased out. No pun intended. We now have high risk chronic phase CML and essentially what we used to call blast phase disease. So things like flow cytometric evidence of lymphoblasts, complex clinical features, which used to be called accelerated phase, may warrant treating a patient more aggressively, or at least being very aware that they may have greater risk of transformation. If they're already in that state after TKI therapy, we have to manage that appropriately, think about the total treatment of the patient, including transplant options, if that's possible, especially in anyone with advanced disease. But in chronic disease and changes in lines of therapy, it can be complicated with multiple TKIs and different disease characteristics and different expectations. And lastly, of course, cost and access. We're doing fairly well in the United States, although I would say maybe not increasingly well when it comes to patients having access. And I know where there are systems where there's supported healthcare, I think it's a little bit more straightforward, and I respect that tremendously. I think this was covered in the last half hour that, as we move through lines of therapy, this is data from the MD Anderson looking at large numbers of patients treated simply with one beyond one line of therapy, 2, 3, or 4 more lines of therapy. And it's quite clear that survival and transformation-free survival are going to be impacted. And this is in the pre-asciminib era. So we may be able to bend these curves, hopefully with better and earlier intervention, I think, maybe with novel agents, not recycling through all of our available agents that it may be more similar and moving more quickly to highly effective therapies. Again, alluded to, when we choose salvage therapy, I think there are some challenges. I think point one would be that after imatinib, which would be a little bit historic now because many patients are started on second generation agents, but if a patient has failed imatinib and we look on the top of this table, what are the expectations for cytogenetic response on dasatinib, nilotinib, and bosutinib? They're not vastly different. There may be actually some advantages for dasatinib and bosutinib, given their potency and their targets, whereas nilotinib may have some potential for more mutational-based resistance. They're all very good, and they're all have good safety profiles, although they have distinct toxicities. If you look on the lower right, there is this data showing that if you combine single center phase 2 sort of single arm trial experience, asking how many patients achieve a complete cytogenetic remission, switching amongst the second generation TKIs versus in this case switching to ponatinib. And I think this was a direction or a signal for us saying new generation, third generation, or evolved TKIs may serve patients better if they've failed 1 or 2 more or more lines of therapy. And we have to be comfortable with earlier and more aggressive switching. The NCCN guidelines were alluded to, and here's just the way we manage frontline therapy. There is also, of course, rank order here based on risk. So risk assessment remains important. A low-risk patient can be offered any of the ATP competitive TKIs that are licensed in the frontline, imatinib, of course, bosutinib, dasatinib, and nilotinib, and where I am. For those with higher risk disease, intermediate or high risk, and again, this is chronic phase disease as judged by the SOCAL, or perhaps a bit more precise might be the ETLS score or the UTO score, some of the European models that look at disease-specific risk and mortality from CML. Those calculate to be higher. We want to think about a second-generation inhibitor as our frontline therapy. Of course, we'd like to always think about treatment-free remission. This is, I think, maybe something we can set as the new goal for treatment in 2023, 2024, and beyond. And we have different sets of instructions from the NCCN on the left and ELN on the right. The major differences are that the ELN is a little, I would say, more conservative in that they do look for a more substantive deep molecular remission by molecular parameters, MR 4.5. MR4 is recognized as acceptable, but for optimum depth and suitability for treatment cessation, they look for that. And they also look at, based on the EuroSki trial, which was a large discontinuation trial, what is the optimum amount of time a patient should be on therapy before they stop? How much time in remission and how much time in deep molecular remission? Those are the two biggest parameters that guide that decision. The key elements here are being able to monitor the patient closely at monthly intervals for some time, and then closer, depending on the case, for 6 to 18 more months, and then having a very good lab and also being able to promptly and appropriately retreat a patient. I think we also alluded to this, but just to give some comments, how do we see patients fail? Or how does the therapy fail the patient, rather? That's probably a better way to say it. Primary hematologic resistance is exceedingly rare, although it can happen. We then, and as we just saw data on EMR, early molecular response, sometimes that's either slow or it's not happening. And that may be ominous, especially if you're using a second generation TKI, if by 3 to 6 months you don't have a fairly good kinetic improvement in BCR-ABL. Cytogenetic remission, but failure to achieve a major molecular remission is another type of kinetic failure. Those patients are probably protected from progression, but they may have more events. We know that cytogenetic remission is a very good response and is protective, but we still focus on major molecular response. For those that are in major molecular response, I think we have a little bit need to be more thoughtful about defining resistance or failure, because it is fairly safe. Many studies show if someone has a prompt major molecular remission, the risk of transformation may be low or almost zero. However, that patient is not eligible for treatment-free remission. They may have more chance for losing response over time. And I think we should aim higher. And of course, we then aim for a deep molecular remission. And then just a quick note that deep molecular remission really is defined as transcript level below 0.01%. A lot of new data, particularly from, for example, the group in Adelaide, Australia, looking at flow cytometric sorting of cells in patients in deep molecular remission where they may have PCR positivity. That may be coming from cells that aren't necessarily myeloid or proliferative and may not be contributing to relapse in all cases. So PCR positive is not failure. Again, I think my colleague used these exact words, unmet needs. So I would say, to summarize, that multi-TKI resistant disease, that would be patients who've exhausted all TKIs. They may have complex resistance. Their fate is generally dictated by what degree of response they've had at all. What's their level of transcripts at the time of decision making. Those can really, unfortunately, tell us about what choices we may need. There may be some patients who have perhaps lesser degrees, but still complex scenarios where they have multi-TKI resistance and intolerance. They may not be able to take enough therapy. They may have contraindications to other therapies, and their prior response may have been good or may have been variable, and they may not necessarily have kinetically active and high-level transcripts at the time of needing a change. We talked about optimum frontline therapy a bit regarding choosing TKIs. I'll get to some nice new data on options we may consider in the future in a bit. And then, of course, we want to maybe salvage patients earlier. We just had very clear data presented by, again, by my colleague about the fact that, as you move through lines of therapy, you're going to lead to differences in outcome, differences in cost, likely, and complications. And of course, the T315I still represents a distinct clinical entity, which requires select drug therapy and consideration. So Scemblix or asciminib really has changed the game. So in the very beginning of ABL kinase inhibitor development, there were multiple targetable regions of the ABL kinase. And this cartoon, I think, helps us understand that the ATP binding pocket was one. So by inhibiting binding of ATP to the pocket, you affect the activation and the activity of the kinase. Catching it in an inactive and active conformation has something to do with the different kinases that are focused on that region. However, secondly, another change in the kinase which occurs with B3-ABL fusion is loss of a domain on the myristoyl pocket, or the myristoyl end of the kinase. And by targeting the myristoyl pocket, you can restore a structural functional change, which then has a fairly strong impact on the kinase and a fairly strong inactivating effect on the kinase, much like or potentially the same or better than inhibiting ATP, which is maintaining activation of the kinase. So these are both targetable areas, and the asciminib development program really was an extension of probably a long search for an allosteric inhibitor that was different than the ATP combining drugs, and it could be clinically effective and clinically available. So that day has come. That drug has been tested extensively. I was able to participate in a fair bit of those trials. It's now licensed in hopefully many places around the world, and it's been studied as we know in phase 1, which is where we derived our safety and our activity data, and as well FDA in the US, and I think other regulatory authorities are looking at data on T315I mutation. Again, we do have labeled use in the US for T315I. We then have an important randomized trial, which really showed us a bit more about safety and efficacy and the side effect profile compared to bosutinib, which at the time was the appropriate comparator for patients needing third or more line of therapy switch. We have some combination data, which I'll share with you. And then we have a host of trials ongoing. We clearly have frontline studies, some completed and awaiting crucial data from Novartis, some pilot or smaller studies from outside of the US, of course. And we're a bit slower, honestly. Our colleagues in Australia have the first data, and we'll share that. We have some data that we're gathering now as we treat patients. There's an important second line study. And that does include dose escalation of imatinib. There's add-on trials. There are trials trying to use asciminib to improve treatment-free remission. There are advanced disease trials, combining it with ATP competitive inhibitors and agents active in blast phase disease, and trials in pediatrics. So if you weren't aware, the ASSEMBLE trial is the benchmark for asciminib data at this time. This was a large randomized trial of patients with 2 or more lines of therapy and failure and intolerance who were lacking MMR, and who also didn't have the select mutations T315I or 299 because of the possibility to randomize to bosutinib. So we weren't studying that population here, but all other patients were eligible. So 2-to-1 randomization of the standard dose of asciminib from the phase 1 trial of 40 milligrams twice daily, or the standard dose of bosutinib per the label of 500 milligrams daily. Many use lower doses of bosutinib, sometimes initially or over longer periods of time to mitigate toxicity. But in order to give this comparison the best chance of judging efficacy, we needed to use a full dose of bosutinib and manage the toxicity. There was an allowance for patients who came off the bosutinib arm to move into asciminib and to be followed. We have some data on that. Stay tuned. That'll be presented at ASH this year. What did we learn from the trial as it read out over multiple different time points? This shows us the fitness and the ability of patients to remain on study. You can see that the majority of asciminib patients remain on treatment, whereas the majority of bosutinib do not. And that continued at week 96. The fraction continued to grow. The main reasons were a combination of lack of efficacy and adverse events. You can see for bosutinib, there were much higher rates of patients needing to exit therapy for adverse events. The primary endpoint of the trial was major molecular response, which, as we've both spoken about, I think that we know that that's an important milestone of treatment and really offers protective remission. So at week 24, the first readout, we had a statistically significant difference, meeting primary endpoint. At week 48, that difference was growing, and at week 96, it continues to grow. In all fairness, some patients who were responding to bosutinib, who were able to tolerate it, continued to do well, and we did gather some more patients. So the bosutinib arm does include some nice responding patients, but the fraction and the continued accrual of patients into relevant deeper remissions on asciminib was clear from this data. The adverse events and all, what we'll get to in a moment. I wanted to quickly show you one arm of the T315I study patients from the phase 1 trial. So this was, as you in the upper left, sorry, it's small, but that's the schema for the phase 1 study, which include chronic and advanced phase, single agent and combination therapies, different dosing schedules of asciminib, but it included a higher dose treatment arm of T315I patients. And this is the demographics of those patients. They generally are very heavily treated with exposure to the full spectrum of TKIs. There were some patients, rare patients who had more than one ABL kinase mutation. And you can see the relative level of transcripts at the time of screening, which include about half of patients who had higher than 10% transcripts, which we know is a tough population. This slide is out of order. Hold that thought on the T315I while I finish talking about the ASSEMBLE trial. I apologize. Back to the ASSEMBLE trial, which was chronic phase CML, not T315I. I showed you the major molecular response rates. This is the deeper molecular response rates. Terribly sorry. Important, as we know, the primary endpoint was major molecular response. The MR4 and MR4.5 deeper molecular remissions mirrored the response we saw with differences between asciminib and bosutinib, with again increasing number of patients in both arms, but fractionally higher numbers of patients with asciminib. Again, based on efficacy and tolerability, we believe a combination. Time to treatment failure. In the ASSEMBLE trial, again, chronic phase, asciminib versus bosutinib was clearly different, with the median time to treatment failure being reached rather quickly, within 6 months, actually, with bosutinib, and not or having been reached at 2 years rather with asciminib. So we can see the difference in some of the important outcomes, and additionally, event-free survival, showed a similar pattern, with a very rapid time for that to be reached, median 50% reached by bosutinib, and asciminib still not reaching 50%, had not been reached even with the longer follow-up that we have from the ASSEMBLE trial. Again, as the ASSEMBLE trial, this is looking at mutations at the end of treatment. This is the standard dose of asciminib versus bosutinib. I think our question here was, what are we going to see with using a myristoyl pocket inhibitor and mutations? So we're going to see a host of different mutations arising. our questions were related to myristoyl pocket mutations, which could be mutations specific to the drug, or ATP binding pocket mutations, which may just evolve based on some other mechanism or drive. So as you look at failure patients or patients coming off treatment, they had either progression or lack of efficacy. We didn't see a high number of mutations. We did see some. Not surprisingly, we saw T315I and 299 emerging in bosutinib. Now that's fairly predicted. With asciminib, we saw some of those ATP binding pocket mutations, no one specific pattern, and we also did see some myristoyl pocket mutations as well. So I apologize; they may not be very visible. They're here in the dark. A337 and P465, I believe. I sorry about the few slide snags. So the overall adverse event profile for, again, back to the asciminib trial. I teased you with the T315I slide too early. The adverse events were frequent in both arms of asciminib and bosutinib, but back to, again, the key differences in this study were that the discontinuation rate was higher with bosutinib, and that was due to specific AEs, and we'll see that here. So the AEs we might have expected with bosutinib, in other data sets would be liver function abnormalities and GI toxicity. You can see that's a fairly clear pattern here. Also important, of course, would be what was more prominent with asciminib and what's more prominent in heavily pretreated patients, which is myelosuppression. There was higher rates of thrombocytopenia and neutropenia, marginal for neutropenia in asciminib treated patients versus bosutinib. That was generally more of an early treatment-related effect and wasn't limiting. So it was, again, maybe more what we'd expect from prior data sets with bosutinib related to toxicity. Focusing on the adverse events that were more common with asciminib, the hematologic adverse events, this tells us about the rate of first ever and then recurring. What this graph on the right would tell you is, does someone continue to have thrombocytopenia and neutropenia at later time points in the study, or do we see new patients being added having late toxicity? You can see the bulk of the toxicity is early within the first 6 months. Again, I think reflecting treatment, the inverse of a treatment effect, where you have myelosuppression in temporarily while normal hematopoiesis needs to recover. The same pattern of clustering early was seen with all adverse events. These are non-hematologic adverse events with asciminib. And there are some, of course, some of the more prominent were fatigue, headache. There was some mild hypertension if we're focusing on cardiovascular or cardiovascular toxicities in general. The frequency over time did diminish for most of these. Some did show some increased accrual later, things like headache and fatigue, again, arthralgias. But the most common adverse events we saw outside of hematologic toxicity, which were limited in the non-hematologic space, were manageable and didn't lead to treatment discontinuation. We do want to talk about arterial occlusive events because this remains an important question. And obviously the scrutiny and the investigation was fairly keen here. So in this randomized trial, thank goodness the rate of events was very low across both arms. There were some more events in the asciminib arm, and they're listed here. And I think it's probably too early to judge what the absolute signal for asciminib is. I think we can say, fortunately, that both of these drugs have a low risk of arterial occlusion. And the most difficult point is that both of these arms include patients heavily pretreated and exposed to other agents. I think our frontline asciminib studies are going to teach us the most about specifically about adverse events and cardiovascular and cardiopulmonary adverse events. So we need to focus a bit more on them. But I think this tells us that we need to be cautious and monitor and, of course, manage patients appropriately. Okay, so finally, the T315I data. I'm so sorry about that misplaced slide. But again, remember, there was a cohort in the phase 1 study of heavily pretreated patients, again, with a fairly high transcript level. And we asked, how did they do on asciminib? And this is it. The main question here might be, had they seen ponatinib or not? And I think there are some differences in the ponatinib naive and ponatinib pretreated patients in the upper left. But the rate of major and deep molecular remission was fairly good. That's MMR on the top and deeper molecular remission on the bottom, which I think is incredibly encouraging. I think the jury needs to maybe still deliberate on what is the absolute best therapy for the most complicated patients, including those with the T215I. And I think the fairest comment to make is that we now have other options that may have a different safety profile. With regards to patients having mutations, we can see some additional mutations, including multiple or compound mutations acquired during or after treatment in those who did not achieve major molecular response or who lost MMR. Not surprising. Just a quick slide on the fact that asciminib has been combined with ATP competitive inhibitors, imatinib, nilotinib, and dasatinib. I showed you that cartoon. We know that asciminib is a myristoyl-pocket inhibitor, and these drugs are ATP competitive inhibitors. So this is the first rational scenario where we can combine the two drugs. We learned specifically that the pharmacokinetics of the drugs is slightly different, and that for imatinib and nilotinib, the dose needs to be modified. Whereas with dasatinib, we probably have more leeway to use higher doses. And these studies are ongoing still, and hopefully we'll see more studies. With regards to the efficacy signal, we might propose that there could be even synergy here. I think, and again, in a heavily pretreated population, seeing cytogenetic and molecular responses, as you can see in the bottom table, with each group and deeper molecular emissions being accrued is very encouraging. And as this hopefully gets published, and then we look at more data and combinations, we'll learn a little bit more. And there's even thought about combining asciminib with other agents, which may be more potent, which could be helpful. So turning to ponatinib, just to kind of to comment, and I know I need to get to some cases. That was supposed to be my job. That's coming in just a few minutes. I hope we're okay for time. Please, organizers, please let me know that that's okay. The ponatinib comparison to asciminib is something we try to do in our minds, and we don't have randomized trials, but we can see that, from the PACE and the OPTIC trial, major molecular response rates there sound a lot like the major molecular response rates we saw with asciminib. What's happened with ponatinib is we've seen it go through other iterations of trials, and on the bottom is the OPTIC trial, which looked at what is the proper dose of ponatinib that we need to use. And we learned that we still need to use 45 milligrams for optimum disease control with subsequent dose reduction. And on the lower right, you can see that does spare us from, it gives us a greater plus versus a minus. We get a much better response for the penalty of some adverse events, particularly arterial occlusive events. So I think the drugs are both useful in this space. I think we learned how to use ponatinib better, and I think we've learned a lot from these two drugs together. I just covered the ponatinib data a bit. That it's an effective drug in T215I. The dose still needs to be 45 milligrams from the OPTIC trial. Footnote: there was a trial called the EPIC trial, which was a frontline trial of ponatinib, which unfortunately was closed due to adverse events. So we may not be able to move that drug into the frontline. The risk may be too great. The asciminib data we've gone through, the phase 1 trial, which we didn't look at in this presentation today, it's been published. We know that we have safety from now almost a decade of treatment. We have similar toxicity across a broad range, thank goodness, because of the era of targeted therapy. That's often common. We see, I would say, less mutational-based resistance, although some mutations are possible, and we see durable, safe remissions ongoing in patients. The ASSEMBLE trial showed us that this agent is a superior drug in later line therapy, from many different fronts, and we need to stay tuned for frontline data and other line data that needs to be finalized. But we have a snapshot from a trial called the ASCEND study, and this is a philosophical slide which just brings some publication literature in about how the drugs are positioned. We may think about either drug in a T215I mutation patient with advanced disease and some very high transcript patients with very complex resistance, and maybe some patients who may have a better odds of response to ponatinib, below. I don't think asciminib is futile there without hesitation. Compound mutations, patients with pancytopenia, those may be difficult for both drugs, but the bulk of patients with intolerance, resistance, perhaps a mix, with some degree of response to prior therapy are clearly going to potentially benefit from asciminib and can be continued. On the lower right, I just bring into to focus the fact that there are yet other drugs being studied, other third-generation drugs that may be ATP competitive, that are like ponatinib, and even other drugs that may be like asciminib. So I think the field will continue to expand. I mentioned the ASCEND trial. This looks at frontline therapy with asciminib in newly diagnosed CML. and this starts from the bottom up. People get the green bar, they get standard dose of asciminib, and then they're adjudicated based on 3, 6, 12, and 18-month milestones. As you can see, if they don't hit all the deepest of milestones, they may have a dose escalation and so on. They actually can have the addition of a second TKI if needed, and that was not necessary so far in the study. So here's the first look, and this is not a randomized study, of course. This is just historic comparison to the Title II trial, which was high dose imatinib. Interesting combination, or comparison. I actually favor higher dose imatinib in my own practice for frontline use. And I think what we're seeing here is that it may be harder to do much better early, although we clearly are doing better earlier, even at the 3-month mark with EMR. But getting patients into complete cytogenetic and major molecular remission within 3 months of therapy, you can see how rapidly this is happening. And I think rapid disease control is going to likely subvert resistance and hopefully move more patients into a potential for treatment-free remission. So this is incredibly encouraging, and we need to look at this data further. We've obviously come a long way. I've been at this for a while. I was mentored by Brian Drucker, who, treated the first patients as seen in the upper right with imatinib, and who theorized that a SGI-571 or imatinib would be an effective therapy for a targeted, in a cancer with a specific target that's driving it, and that has really come to fruition. So let's close with a few cases. I hope we have some time. Here's a few of, I would say, cases that might offer some thought. This is a middle-aged man with CML and chronic phase, diagnosed a little more than 10 years ago. Nothing particularly ominous here, some splenomegaly and chronic phase CML features, who was treated with nilotinib and had hematologic but not cytogenetic complete remission with waxing waning PCR. He's then studied and is found to have a P-loop mutation, Y253H. He's briefly put on dasatinib, and unfortunately, he has loss of hematologic response. He's then seen at a referral center in New Jersey, and is I'm practicing in New York, and is switched to ponatinib. And again, this is a second-generation failure with a P-loop mutation who's had 2 drugs. After ponatinib, he had some response and was dose reduced due to the FDA scrutiny of adverse events. So again, into MMR, but had some arterial hypertension develop. And he had into therapy, 1 year into therapy, unfortunately had a rise in his transcripts. And again, this was 3-drug exposure, nilotinib, dasatinib, and ponatinib, has a 255K mutation, lost MMR, and is now lost complete cytogenetic remission equivalent. So he is one of our phase 1 patients. So multiple mutations, 3-drug exposure, including ponatinib, and this is how this patient's transcripts evolved. He had, I would say, slower kinetics of initial therapy, and then probably is leading the way for us to understand that dose increase may be relevant in many of these patients. He then went into a complete molecular remission and continues to sustain that, I think now 6 years later.
You have 2 minutes more.
Okay. He had, again, the dose increase allowed and no adverse events, and was on to the rollover study. Here's a second case, a 62-year-old nurse with chronic phase CML with some comorbidities. I think that's important, who had more robust chronic phase CML, high white count, platelets 1.4 million, also treated with nilotinib, unfortunately had toxicity, dose reduced, PCR remission not substantial, perhaps due to the lower dose exposure, perhaps due to the disease. Due to tolerability issues, was then put on imatinib. Same complications, dose reduction required, PCR remains high, unfortunately, then switched to dasatinib. Now has this toxicity on that with liver function abnormalities and diarrhea. Now her transcripts are rising. She's had 3 drugs already. She's on to her 4th. I think this is a case that exemplifies the recycling struggle. She has challenges with bosutinib, warranting steroids and dose reduction, et cetera, and really barely squeaks out a molecular response to 400 milligram bosutinib. Mutational testing shows a 35 base pair insertion mutation only. So she switched to ponatinib and has really a slow kinetics of response, although some improvement. She has hypertension develop. She does establish an MMR, but her blood pressure becomes more difficult to treat and she's not in a complete molecular remission. So I think this is a case of ponatinib intolerance, and moving a patient to a safer drug who has cardiovascular risks and multi-TKI exposure in order to improve their response. And she had improvement in her hypertension, and her PCR remains near deep MR on asciminib. I think in the interest of time, I'll skip these additional cases as I was instructed, and I will say in summary, and I can share these slides if the organizers would like, that asciminib really does offer advantages in late line therapy. Mutational resistance appears less. I think this is an opportunity for you in Saudi Arabia, given the nice presentation earlier and about how you might want to think about this into your treatment armamentarium. And I'm hopeful that we might see this as a potential second or frontline agent soon. So I thank you for your attention.
Thank you, Prof. Moro, for this comprehensive review and this presentation about update in chronic myeloid leukemia. Because of short of time, we'll just see the questions in the chat. We have here one question from Ahmed Al Fawzi. His question is abscessimab approved for second TKI intolerance without T315I mutation?
So in the US, the FDA said treatment with 2 or more TKIs with resistance or intolerance. There's no requirement that someone has to have some transcript level. Intolerance begets resistance. So if a patient can't take therapy, they're likely to not perform well. So yes, I've treated patients with multi-TKI intolerance. I think you have to think about those cases because they may have other options as well. But I think asciminib is a safe and effective option, and maybe a highly effective option in that setting.
Excellent. Thank you. Here we are concluding. We will conclude here, and we would like again to thank Prof. Mero and Dr. Malhan for this comprehensive review and update about chronic myeloid leukemia. It's actually helped us to change our practice in CML. And I'd like to thank SSBMT for this review, for this event, and thanks again for Novartis for sponsoring this event, and thanks to everyone for listening.
Thank you.
Thank you. Have a good night.